What's going on, ladies and gents? Welcome to another debrief with Peter and Matt here. Pete's still in San Diego. He's doing nursing, enjoying his summer out there, and I am still on my nurse break for the next few weeks as I might be picking up an agency in Chicago, so we'll see how that goes. I'll update you guys in the next debriefing because I am going to just start this process. What's going on with you, Pete?
The same old is actually nice because I haven't really been floating these last couple of shifts. I've just been in ICU literally for 3 shifts in a row. So it was very nice, very refreshing. I feel like I got to hone in a little bit on my skills. I feel like people are getting a little bit sicker, or at least the patient that we've had these past couple of weeks, they've been a little bit sicker than they were back when we were both working here, which is interesting. And
It makes things fun.
Oh yeah, for sure. And I never actually spent time in San Diego this late in the summertime, you could say, or this early, whenever the first day of summer is. I don't know if it passed or what, but I've never really been here in July, so it's super hot. It gets super hot. Usually we're here in the winter months, fall months, spring months, so it's not super hot, but it's been kind of hot here for the past couple of days, which is nice. But back to work. It was nice being in the ICU for more than one shift every 2 weeks. People are getting pretty sick. I've had some pretty sick patients. I've been getting these last couple of shifts definitely a higher acuity of patients compared to all the other nurses, which is actually pretty nice because I feel like sometimes they give travel nurses, like the softer patients, easier assignments just because maybe we don't know exactly what to chart where, so they tend to just give the more complex, difficult patients to their staff, which makes sense. But it was nice. And even like in the huddle, they were saying, because we had a one day where we had a lot of sick patients, and even in the huddle when they were giving us like a little debriefing or whatever before we went on shift, the day shift was like, we have these patients here. I think I'm gonna give them to the staff nurses over the charge nurses, or not charge, but over the travel nurses. But then the other nurses were like, nah, go ahead, you can give whoever you want to Peter and to whoever else there, because they're really good nurses. So I got like the sicker patients, and that was actually nice. I actually feel like I did some ICU critical care stuff.
So what kind of patients did you get?
So one of them ended up passing away. He was really sick. He was a DNR. So I'm not gonna really talk much about that because he was DNR. So we were just giving meds. I had to put him on a pressor, and then I maxed that pressor out. I had to start another pressor on him, max that pressure out, and then it was cool because the physician came by, assessed the situation. He's saying, how's he doing? I'm like, he's not doing very well. His liver is shot. His AST/LFTs are through the roof. He hasn't made any urine in the last 2 days, and we're just giving him fluids. So I think that we're not doing anything that's going to help him recover. I think he's beyond that point. So it was nice because the physician actually came by. He agreed with me, and he actually called the family. And the family said, yeah, thank you for calling. We're aware. And just to let things pan out the way they are. They didn't want to withdraw care or put on a hospital or anything like that, because it was an interesting case, because before the patient got intubated, one of the family members was there, and he told the family member that he wants to stay alive. That was right before they intubated him. So the family member felt guilty pulling the plug, even though everything that we did was not going to help him. He was already past that line of being able to come out of his state. He was basically comatose. He had no responses to anything, no cat. He did have a cough and a gag when I first had him, but then as he declined, no cough, no gag. He was starting to look gray and pale. Nothing was perfusing. We had him maxed on pressure, so obviously that's going to push all that blood and volume towards your organ, towards your heart, and he was just not looking good. But the family member didn't want to pull the plug just because of what the family member said right before he was intubated. So he's like, we're not gonna do CPR. Just keep him on the medications, but they didn't want to pull the plug, which I respect in that situation. I know the patient had basically no outcome. Nothing was ever going to change with him. He only going to decline. But I understand how the mixed emotions could get involved when your loved one tells you, hey, I want to still be alive, when you know that they're going to die. He had like a end-stage cancer too, but still, it is what it is.
And that's the hard part of nursing, because there is always a gray area. It's not black or white. So if somebody tells you, I want to be kept alive, well, we can intubate you. We could put you on 1 out of the 4 pressors, but where is the gray area? Where do you draw the line, especially if you have that guilt because that family member said he wants to be kept alive? So I understand why things got pushed to that degree as far as him being on pressors, intubated, and I'm glad that at least they did a DNR and understood the severity of the situation due to his cancer, and they were able to, or he was able to pass peacefully.
Yeah, and I'm glad that happened that way, because a lot of times, like, you know yourself, it's usually the family that keeps this patient alive, that's always trying to push for their health. When you know there's nothing else to be done, they still push the envelope. They want a full code, and that usually ends kind of brutally. But another patient that I had, this may want to push you away from going back to bedside while you're on your little break. I had a patient. He came in from a different unit. He was a transfer up. He was decompensating. He was looks like to me he was fluid overloaded. He was hypotensive. So they transferred him up to us, the ICU, just so you could kind of keep an eye on him longer, manage him a little better. And he came up to me with an ileus versus obstruction. They weren't sure. The CT wasn't that clear. They weren't able to give a definitive answer. So, long story short, came like 6 o'clock in the morning. I come out, I do my last assessment, make sure he's okay, get him ready for days, make sure he looks nice. And I walk in the room, and I see a little bit of brown spot on the sheet that he was covered with. So I'm like, all right, he probably, dropped the deuce, probably took a poop. And as I get closer, I see blood on the pillow. I'm like,
plot thickens.
Yeah, plot thickens. I'm like, God damn, why is there blood? Maybe he's like oozing from a dressing site, because we just placed a such line in him. We had a difficult time. So I was like, maybe, yeah, probably just oozing a little bit. And I walk up closer and closer, and I see like blood spewing out of the port of the lumen, out of a central line. And I'm like, what the hell is going on here? How is this lumen ripped off? So there's blood coming out of the lumen. He had a triple lumen. It seems like he bit off one of the lumens of the triple lumen, because there's no way he was able to pull out anything because he wasn't strong enough. So somehow
Where
he
was
got
his lumen on his neck,
IJ,
or his
yeah.
arm, his
it was
IJ.
right IJ, yeah. So I'm thinking maybe he pulled it off, but I'm like, he's not strong enough to reach over there. So somehow he was able to get his neck turned where he was able to bite off this lumen, and there was blood gushing out of there. And his hemoglobin came back at 9, but I took his blood before I went on break, so that was like, you could say, an older lab. I guarantee he lost like at least a unit of blood. His hemoglobin was probably down to like 8.5 at that point. And to make matters worse, I uncover him, and there is literally poop from his waist all the way down to his toes. So this guy has poop from his waist to his toes, and he has blood from his waist all the way to his head. So it looked like
Ileus resolved.
Dude, Ileus is resolved. So I told him in charge, I'm like, hey, he's probably doesn't have an Ileus anymore. And she's like, oh, why do you think that? I'm like, because he just shit the whole bed. And then I got one of my coworkers to come help me. He's like, what the hell happened here? I'm like, bro, I just came in here. The same thought in my head is going through yours. I don't know what the hell happened here, because it looks like a straight murder scene. Like, this guy he's calm in the bed, but there's blood half the bed and there's poop half the bed. It literally looked like somebody just died over there. So I was like, what the hell?
That was the most traumatic thing you've seen as far as walking into a room?
Dude, it was the biggest mess I've ever seen in my life. My buddy was literally holding both his legs up in the air so I could wipe the bottom of his leg. That's how much like stool there was there. He was literally, if you walk in the room, there was one guy holding up 2 legs. Like, you know how the women have those triceps or whatever they're called? When they're giving birth or whatever?
Oh, yeah.
He's literally holding up like that, and I'm wiping him down. And people are probably looking at him like, the hell's going on in that room, So that was wild.
How did you clean this up, man? It must have been using a bunch of towels.
Dude, man. It was a mission, bro.
That's the worst thing. When you have a poop situation like that, you're trying to figure out, should I use a couple chucks? Should I use like a bed sheet and cover up the poop first, then turn him, then clean him? Sometimes it's such a sticky situation, you have no idea where to start.
Bro, and to make matters worse, this patient was bedbound, and he was heavy, dude. He was like 290 something heavy. So that makes things so much worse, man, because he couldn't turn himself, so we had to get help. It was just a mess. And I like clean him up. I'm like, look at the charge. I'm like, I'm throwing all this out. I'm not separating the linen from the chalks, from the paper. It's all going to garbage. I literally threw all that inside. And what was funny is because I come back the next morning, and they're like, and the room where that patient was, it got the toilet got clogged somehow, and it flooded with poop. Poop was wow. Backing up, and the whole floor was covered with poop, so I had to get maintenance in there, which was funny even itself, because this guy just took a massive shit, and I had to clean him up, and the next morning somehow the toilet was backing up with stool, which made, I was like, you can't make this shit up, dude. You can't make this shit up.
Were you guys throwing the wipes away in the toilet and flushing it?
No,
or?
I threw everything in the garbage, dude. I didn't even use wipes. I used a towel. It was impossible to use because they have those fake ass wipes that are like foamy wipes.
Yeah,
I hate those
do
things.
with those.
Yeah. So I just towel them up and I'm like, I'm throwing everything in the garbage. Because it was like, get me thinking. I'm like, did I throw anything down the toilet to clog it up? And I didn't. So it's like, it was just funny. I walk in, I'm like, I don't know, like what are the odds? What are the odds of like the patient shitting himself and then totally backing up with poop?
Yeah, it makes one of those great nursing stories you can tell for generations, as far as like your kids or other nurses that come in. Like every single time a new grad is going to be upset about cleaning up poop, and you're going to be like, well, let me tell you about a story, and this is where it starts.
Yep, and we wipe a lot of poop.
You also told me you had a patient with a pacemaker.
Yeah. So I haven't had a patient with a external pacemaker in a while. I think the last time I had it was maybe in Santa Monica when we were working together a year ago, maybe even before that. But yeah, patient came in through the ER for bradycardia. Did an EKG. So it was junctional in the 40s. Hadn't made any urine. She had a chronic Foley. Hadn't made any urine for the past day or whenever those symptoms first started happening. So they had to put pacer wires in her, and she needed a permanent pacemaker. So they dropped transvenous wires. So they went through her IJ, dropped the catheter through there, and then they took the wires and guided them through the catheter into her heart. Great. And then they sent her over to us. I got her at the beginning of my shift, and she was perfectly fine for an hour, making urine. Blood pressure was great. Settings were right where it's supposed to be. She came in with me at a rate of 90, a output of 11, and a sensitivity of 2. I was looking at the settings. I'm like, that's kind of high. Usually, we don't put people on a rate of 90 unless we want to increase their cardiac output. Because usually when I get pacemakers like that, they're either in like the 60s or 70s, or it's a backup rate of like 40 or something like that. So 90 was kind of high. And then an hour later, the alarm starts ringing. I'm like, the hell's going on? Her heart rate's in like 60s, 70s. And I'm looking at it, and I'm like, the pacemaker isn't pacing it properly, because I still see pacer spikes, but they're not in the right area. So I'm like, oh shit, I don't want to get the RNT phenomenon. So I run in there. I'm like, damn, let me start messing with these settings so I can figure out what the hell is going on. So I was messing with the settings. First, I went up on her output from 11, slowly, little bit by little, one by one, and it wasn't working. It wasn't picking up. So I maxed out on the output of 23 or 24 it was, and it still wasn't working. Because my first thing was that, hey, maybe she's not being paced at 90 because maybe the output isn't strong enough. Maybe the electric shock that she's getting isn't strong enough to pace her heart. So I brought it.
Would that be a failure to sense? I always mix up the two.
That'd be a failure to pace.
Failure to pace.
Yeah, if you have a low output, it's a failure to pace because you're not giving enough shock for to pace the heart. So I maxed it out and nothing, still the same. So I brought it back down to 11. I'm like, maybe it's not sensitive enough. Maybe it's failing to sense. So I went down on sensitivity all the way to the lowest setting. I think it's like 0.5, because if you want a pacemaker to sense more, you have to go down in sensitivity because you lower the threshold so it can pick it up easier. It was at 2, so I brought it down to 5, thinking that, hey, maybe it'll pick it up on a lower threshold because maybe it's not sensitive enough, and that didn't work. Then I'm like, shit, what the hell do I do? I have her on the smallest sensitivity and the highest output and still not being paced, and she's like, I feel my heart's kind of burning. I was like, oh shit, well, if you feel kind of warm in your chest, let me bring that back down to let me bring back down the output because it's obviously too strong. And then the nurse comes in, brings her right down to 70, and she's like, oh, she's better now. I'm like, just because you brought down to 70 and her heart rate is 68, 70 doesn't mean it's still working. You know, just because the pacer's at 70 and her heart rate's 70 doesn't mean it's working properly. Just because you brought it down to 90 doesn't mean it's fixed, you know? And she's like, hey, leave her alone. She's fine. I'm like, yeah, but, you know, it's still not being paced because I was looking at the pacer spikes and they were not even in the right place. So like, I want to say 30% of the spikes were before the QRS, which I should have mentioned, she was VVI. So she was just ventricularly paced. She was VVI. I'm looking at it. I'm like, these QRSs and these pacer spikes, they're completely different. They don't match. They match up like once every third beat or something, which isn't good. So I'm looking. I'm like, what the hell is going on? 'Cause I'm trying to troubleshoot it before I call the doctor because I feel like I could fix this. And I'm looking. I'm like, she came in junctional. So if your junction rhythm means you don't have any PR complexes, and I'm looking at the rhythm, I'm like, damn, there's PR complexes. So she has a whole PQRS complex. She has the full complex of a normal sinus rhythm beat. So I'm thinking in my head, I'm like, maybe she converted from junctional to silent rhythm now, because technically she's not being paced anymore. She was coming up with her own beats. So I called the MOD on call. He's like, hey, what happened? I explained the situation, what happened. He comes by. He starts messing with the settings. He's like, okay, I don't know what to do. I'm going to call the cardiologist. He calls the cardiologist, same thing, mess with the settings. Did the same thing that I did. I told him that I did it. They can't get it. They can't figure it out. They don't know what's going on. And then the cardiologist hangs up, says it's a monitor overnight. If blood pressure's fine, it's fine. And then the cardiologist later on, half an hour later, calls me back. She's like, hey, are you the nurse taking care of him? I'm like, yeah. She's like, I'm not sure what the MOD told me, but let me hear your story. Tell me what's going on. So I explained that, hey, patient came in, and she was being paced at 90. QRSs were being paced properly. Everything was looking good. An hour later, she stopped being paced properly. I told her the whole spiel. I tried to adjust everything. And then I told her, hey, do you want to maybe turn off the pacemaker, see what her intrinsic rhythm is? And she's like, no, not really. Let's just turn down to 30. And we turned down to 30. And of course, the patient's rhythm is still the same, 68, 70. So I'm like, okay, I turn it down. She's like, okay, well then I think the wires might be in the wrong spot. That's why she's not being paced properly, which makes sense. They probably weren't in the right spot. And then I'm like, okay, so you want me to just leave her like this? She's like, yeah, put her back on the rate of 70, or don't put her on 90, put her on 70, don't put her on 90, and just leave the sensitivity and output 11, and then leave it the way it was, and just call me if anything happens. She's like, I'll order dopamine if she drops her pressures, but as long as her pressures are good and if she's making urine, you don't got to call me, everything's fine. Which I'm like, okay, at least, every cardiologist is aware, notified, I got the medication. Her blood pressure was fine the whole day, or the rest of the night, everything was fine. She was making great urine, 100 an hour, blood pressure has been 130s. She likes a little hypertensive, 130s, 150s, and she was fine. But nobody wanted her to listen to me and just turn it off, because she was in silent rhythm. It looked like to me the pacemaker wasn't doing anything for her, any kind of benefit. I feel like they kind of just want to leave it just as like a backup, because when she turned down to 30, her rhythm was still the same, which means that her heart was working fine. She doesn't need any kind of pacer support.
It seems like that was the right move to do, maybe, but it's a liability if something happens and they're like, well, we have pacer wires. Why wasn't she being paced? Why did she Brady down or potentially even code? So it's almost like an insurance policy to have this patient being paced at that time. Same thing with like the patient has some chest pain, they get sent home on a statin. Even though their LFTs are fine, they don't have any cholesterol, they still do it as a insurance policy for the doctor to see they did some kind of interventions, versus a week later, patient gets a heart attack. Why wasn't the patient on a statin? It kind of goes back to that doctor.
Yeah. I mean, I was for sure, yeah, I agree with everything you're saying. I was definitely nervous overnight, but then I kind of calmed down because the patient was making urine, and she was not hypotensive, so which means her heart was doing everything that it needed to. She getting proper cardiac output, so that kind of calmed me down a little bit. And plus, I had the dopamine worst case scenario, but still, it's a pacemaker, it's a extra pacemaker. So you're always thinking like, hey, what if this patient does Brady down, does go back to junctional? Is this pacer going to be able to pace her properly? Because if it's not pacing her properly now, then is it really going to help her out in like the long run? But the fact that she came with this pacemaker and it was pacing her in the first hour of the shift properly, and she was making urine, she had good cardiac output, good pressure, I was kind of okay with it. Even though I'm still looking at it and I see patients like all over the place, so I was just worried about like that RNT phenomenon. Because I think it's with pacemakers, right? RNT phenomenon, not just with like getting shocked, right? If I remember correctly.
Yeah, it's usually with the pacemakers, RNT phenomenon, even if it's external or internal pacers.
Yeah, I even tried to like troubleshoot it where I laid her on her side, so I could maybe by laying her on her side, the wires will adjust. That didn't seem to work, but she was fine. She went to get a pacemaker the next night, which I think she did. I left her, before she went into the OR. But it was a kind of like a trip, because I haven't had a pacemaker in a while. So I was like, shit, how do I troubleshoot this? Especially if you hadn't had one, because usually if I don't have something for a while, like let's say, what is that called? The bladder irrigation, continuous
CBIs.
Yeah, I remember when I had a CBI patient, everything was going good, so I had time to look up the whole CBI process on YouTube and look up some notes. But here it happened so quick, because I had another sick patient, that I didn't really have a chance to familiarize myself via the Google doctor, so I could troubleshoot worst case scenario. So I kind of just troubleshooted it just out the dome, and I'm I'm glad that I used to work in a cardiac ICU where I honed in on those skills where a lot of times nurses wouldn't really know what to do. So if you ever have an external pacemaker and you're not sure what to do and it's not being properly paced, try to go up on the output and go down on the sensitivity, because that tends to help. And also a good practice for future, just in case maybe you might have a pacemaker in the future, if the settings has a V in it, it's ventricularly paced. If it has an A in it, it's going to be atrially paced. Something easy to remember. My patient was VVI, so just completely ventricularly paced.
And even when I worked in LaGrange, sometimes we got pacers just a standby where they weren't on. So if you have a pacemaker like that, just know that if you press that emergency button, automatically there's a default of settings that get put on a pacemaker, so you don't need to adjust anything. It'll just get put to a standard, so you don't have to freak out if something happens. Because I think that was like my biggest irrational fears. I have this pacemaker, what do I do with it when this patient's heart rate is tripping, in a sense? And it kind of reminds me of like the meme a couple days ago that came out, which was talking about med-surg nurses when the patient codes and the nurses are coming up to the patient and looking at them. They're like, oh, I think he stopped breathing, and they're still trying to figure out what to do. So yeah, sometimes in big scenarios you just freeze up and act up, but just know your basic skills, and just like we always said, the ABCs.
I really honed in on my skills. I remember having this one patient back in Illinois. No one really knew what his underlying rhythm was, so I was told that his underlying rhythm was asystole, and he was also transvenously paced. And that was the scariest moment of my life, because sometimes the doctor would tell you, hey, turn off the pacemaker and see what his rhythm is. But they wouldn't always be there by you to do it. And it was common practice for us every shift to turn on the settings to figure out what the underlying rhythm was. And I was a new grad, and I turned on the settings, and I'm looking at it, and it's like 3 seconds pass, and I don't see a beat. And I'm like, oh shit. And I turn it back on real quick. And that was like this, for me, that was one of my scariest moments, because I literally saw a flat line there when I went to check his intrinsic beat. And I was like, oh shit, this guy really is asystole without this pacemaker. And I was scared, because I'm like, holy shit, what if I turn on this pacemaker and it didn't work properly or something? This patient would have probably died. And it was scary. But ever since then, I learned my pacemaker settings and how to work pacemakers, because that just scared the shit out of me. Because I'm like, oh shit, you mean I'm going to have a patient that possibly might not have a pulse without this little box giving him a pulse? I was like, oh shit, this is probably something I have to know, because just in case I get one of these and this is the same situation, I'm not going to have anybody to ask for help. Of course you are, but as a new grad, you're thinking, hey, I'm not going to have anybody ask for help, And
that's the beauty of working ICU. It's a gift and a curse, where you have all these things you have to deal with and do, and it's critical situations. So yeah, thank you for sharing your viewpoints on your shift, and we'll see you guys in the next debrief.
Yeah, thanks for tuning in. Have a good one.
Peace, guys.